Good afternoon, everyone. This is Brian Robson, the Executive Clinical Director here at Healthcare Improvement Scotland. And welcome to this, the 6th QI Connect of 2016, and in fact the 25th since we began 3 years ago. This series came from a request from our national clinical leads here in Healthcare Improvement Scotland to connect frontline clinicians interested in quality improvement with international leaders in the field. They asked that we make the sessions short, accessible and recorded to allow access at a time that suited them. And since that time, our QI connectors have expanded beyond clinicians and into other groups across the globe, and we'll hear more about them just in a moment. However, good afternoon and welcome to Jennifer Graham, our coordinator here at QI Connect.
Thanks, Brian, and welcome everyone to this afternoon's session. So I'm just going to take you through a couple of quick housekeeping slides to get us started. If you could please use the chat function that you see on the right-hand side of your screen to communicate, and I'll just talk you through this in a moment. If you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the event manager using the chat function or by pressing *0 on your telephone. So these sessions are designed to be a really fun, interactive learning experience, so we do encourage you to use the chat function to share any questions, comments or ideas through the talk. And there'll be an opportunity for Q&A at the end of the session. So if you could just click on the speech bubble with chat there circled in red, and then you just type your message into the chat box, select all participants and press send. We'll also be sharing some hyperlinks within the chat function today to some resources mentioned by Derek, so keep sight of that. And here's where I promised it was going to be fun and interactive. So this is a really nice way of just getting a feeling of where you're all joining us from today. So we're just going to ask you to click on the annotation tool circled there in red, which looks like a pen, and then just click on the arrow that you can see on the left-hand side of your screen, and now just click on the map where you're joining us.
Excellent. We can see the QI connectors joining from all over the UK. There's a slight delay in folks out with the UK, so please wait and the arrows will come up, I think, Jennifer, is that right?
Yes, that's right.
Great.
And if it's not working for you, just maybe just say hello in the chat box as well, and that's a good way to get started. So welcome to everyone today, and I'm just going to hand you back to Brian now, who's going to tell you a little bit more about the QI Connect series. Well, there's a few.
Wonderful, and great to see so many people joining from across the globe. Welcome to you all. Now, QI Connect has now extended its reach further. We now have 432 organisations who sign up for QI Connect, a further increase from the last episode. However, those of you that have been with us before on QI Connect will know that this is a competition time. We're absolutely delighted to say that the number of QI Connect, the number of countries joining in with QI Connect has now reached 47. And we have a new country, and I'm going to name that country for you. And when that country is named, I'd like you to put your arrow on that country's flag. So the new country is Kuwait. And maybe, oh, nearly, we're close but no cigar. Okay, Emily Aveling. Welcome, well done, Emily Aveling. That is indeed the Kuwait flag on the bottom right of the screen. And welcome to our colleagues from Kuwait University who are joining us for the first time today. And we'll make sure that a QI Connect mug gets to you in the very near future. We're also delighted to say that when we started this series, we had only one slide with the various organisations that were joining us, and we now run to 13 slides full of wonderful organisations across the world who are all interested in improving health and social care across the world. Absolutely delighted to see you all here and to see your wonderful logos representing your organisations. And of course, we're absolutely delighted to have every NHS board in Scotland joining us for the QI Connect series also. And we always do a special shout out to our friends in universities across the world, and our university total is increasing all the time. And we have a special mention to our new organisations joining us today, of which we have a total number of 10 new organisations across the globe joining us for today's QI Connect. We're also delighted to say that we record the series, so you can listen to the series live as our colleagues in the Golden Jubilee Foundation Improvement Club are doing as we speak just now, but also as our friends in Ko Awatea in New Zealand and others across the globe, they will watch the recording, which is available on our website. And the website is now a rich library of wonderful talks over the last 3 years, and many people are using the library to listen and learn together based on the QI Connect talks. And again, we're always delighted to highlight our arrangement and partnership with ISQA, and the QI Connect series is now an approved resource within the ISQA Fellowship Programme and used across the world. Delighted with that partnership. And we're also delighted to say that the small QI Connect team has been refreshed with Ross Stewart joining us back. Welcome back, Ross. And also a new addition with Alex Stirling, a consultant in public health medicine with the ISD here in Scotland, who is now helping us with our Twitter analytics. Welcome to Alex. And we're delighted we'll hear later in the call from Arvind Varia, who is a consultant in medicine and our national clinical lead here at Healthcare Improvement Scotland for the Scottish Patient Safety Programme, Safety in Medicines work. Welcome to Arvind, and we'll hear from Arvind a bit later in the call. And remember, we're trying to be very active on Twitter. It extends our reach greatly, so please tweet as you learn. The hashtag is hashtag HISQIConnect, and you can follow us at HISQI Connect also. So that brings us to today's speaker. Our QI Connect speaker today is from Fife in Scotland. He graduated in business from the University of Strathclyde here in Glasgow, but he could never have imagined what his career would hold in store for him. He entered the Scottish Civil Service and held increasing responsibilities for policy areas as diverse as fisheries and local government, and was the Chief of Staff for Scotland's First Minister's Office. Derek Feeley really made his mark when he entered health in the Scottish Government. He was a lead civil servant in 2005 for the 20-year forward look for the NHS in Scotland, led by Professor David Kerr, and undertook a Harkness Fellowship in California with Kaiser Permanente the following year, studying service design for patients with complex chronic disease. Derek latterly finished his career in the civil service in 2013 as the Director General for Health and Chief Executive of the NHS in Scotland, and was decorated for his services by the Queen. And Derek moved to become the Chief Operating Officer at the Institute for Healthcare Improvement, where he is now the Chief Executive and President of this global improvement organisation. Good afternoon and welcome, Derek.
Thank you, Brian. It's great to be with you.
We're looking forward to your talk, Derek, and I think Jennifer's going to be running the slides for you. So we look forward to hearing about your contribution to our theme of innovation and integration.
Thank you, Brian, and thanks for that wonderful introduction. Of all the introductions I've ever had, that was easily the most recent.
And I've heard that before, Mr. Feeley.
Yeah. You'll probably hear a few things today that you've heard before, and at least you'll hear them in an accent that you're familiar with. As you can probably tell, I haven't yet, folks, got a strong Boston accent, but I'm working on it. I do have to have people who correct my spelling these days. I'm in the Royal Free Hospital in London at the moment, and we've been doing a presentation back to the staff that we've been speaking to this week just over the last couple of hours. And I've started to spell things in American spelling. It's just kind of happening automatically now. I spell behaviour without a U. I've got far too many Zs in my spelling where I should have an S, but I'm going to try and speak to you still in my native tongue. So I'm going to talk largely about innovation and some of the challenges that we face as we try and innovate around health and social care integration. But also some of the opportunities that I think that present themselves as we do that. And I'm going to prompt you, if I can, to think more radically about what we might achieve if we really could get innovation to be thriving in the work that many systems are doing across the world to try and integrate health and social care. So Jennifer's going to work my slides, and Jennifer, I'm ready for the next one. So what do we mean by innovation? So it's defined in Webster's dictionary as such the act or process of introducing new ideas, devices, or methods. And I like this definition because it makes two important points, I think, about innovation. And one is that it's a process. Innovation is not an event. It takes time, it takes intentionality, it takes some design. And secondly, it's a process of introducing. Definition is about implementation. And if Jennifer just takes us to the next slide, you'll see how we think about this at IHI. We think about innovation as a bridging function. It's how we connect ideas that we harvest from all over the world, and it might be around interventions or services or technologies or behaviours, and how we move those through into widespread practice. So innovation is the bridge between ideas and implementation. And just have that in the back of your mind. When many people, I think about innovation as creativity. It's coming up with the new ideas. And that's an important first step in an innovation process. But the true benefit of innovation is that it helps you to move from conceptualization of an idea to implementation of a practice. If you go to the next slide, Jennifer. So why do we need it, and why do we need it in health and social care right now? Well, our operating environment is changing. The way in which people are expecting and receiving health and social care services is changing. The traditional relationship between patient or service users and provider is changing. People have got accustomed now to 24-hour services, that being able to access services at the click of a button or the move of a mouse, and we in health and social care need to respond to that. The second idea of volume to value, I've wondered about whether to put in or not. As I speak to people in the United States, this is a big issue for them right now. But I think it is also an issue for those of us in the UK and in many other parts of Europe, because money is tight. And the one thing that we all have to do as we're thinking about how to continue to provide the highest quality health and social care services to people in times when money is tight is we need to be able to generate maximum value from every interaction. And so we need to start changing our mindset about be about rather the value secured for that interaction with the patient rather than the number of such interactions. Health and social care is now everywhere. It's on your computer. It's it's in your home in a way that never used to be the case. It's coming to a supermarket near you, and that needs a kind of that provides a number of opportunities that probably require some innovation. The population is aging, and that is placing some new demands on the system, but it's also giving us a fresh set of opportunities because that aging population, as they retire, and although they're retiring later and later, they probably will still retire, it becomes then an asset that's available to us. And we know also that if we could find a way to deploy those assets, then not only the system gets a benefit, but the older person gets a benefit. The economic situation is here to stay, and we're going to continually be challenged to get more from the same. And finally, we need new ways to think about wellness and health and social care integration is prompting us to do just that. Jennifer, the next one, please. So how do we address these challenges? Well, as those of you who have been involved in quality improvement for some time will know, there are no miracles here. There is no magic. We need to be thinking about our processes, and we need to be applying both improvement techniques and approaches and innovation approaches and techniques. And there's a big debate currently about are innovation and improvement, are they different? Are they the same? And I think in my position on that would be often that innovation is a precursor to improvement. If we're uncertain or have insufficient degree of belief that we have a set of interventions that are going to get us the outcomes that we want to achieve, then very often a process of innovation will secure that higher degree of belief, and it will enable us to move into the improvement work that we're comfortable in. And I kind of rather see them as complementary to each other rather than as two separate things. But there is, in either of those domains, there's no magic, there's no miracle, only a set of things that we really need to do. Next slide, please, Jennifer. One thing's for sure, the answer to tomorrow's problems isn't the same as we did yesterday. Learning and innovation go hand in hand. And some of you may have heard the story already of that vessel on the slide there. That is the Thomas W. Lawson, the world's first 7-masted schooner. And the team that came up with the idea that we needed a 7-masted schooner were responding to the challenges of the coming of the steamship. And their answer to that problem was, well, let's add some sail. It didn't work, unfortunately. Unfortunately for the people who sailed the Thomas W. Lawson, because it ran aground, it was inherently unstable. And the lesson from it is that more of the same is almost certainly not the solution to some of the challenges that health and social care integration is trying to resolve. Ironically, the vessel ran aground off the Isles of Scilly, but nevertheless it ran aground. We shouldn't make the same mistake. Jennifer. So we need new thinking. We need a new kind of approach, a new mental model, and we need to be thinking about how we develop innovative approaches to tackle some of tomorrow's challenges. But it's not easy, it's very difficult, and I think I've tried to use the next few slides, and if I can just move on to discuss why some of that is challenging right now. And we've been doing some thinking with a group of organizations in the United States that form our IHI Leadership Alliance, and you can see them listed in, I'm sorry, pretty small writing there on the right-hand side of that slide, but we've been working on them to figure out, so what would it need to take control of this environment to lead this change from the inside out, to work with our staff and our patients, families and communities to really create a new set of service offerings that gave patients the benefits that we wanted to see, rather than responding to the outside influences of legislation. And so this is relevant in the United States at the moment because we've been seeing the Affordable Care Act being implemented, and it's having some real impacts on the number of people who are covered by care, but also the prompting people to think about new methods of delivering that care to patients. And I think you've seen it in Scotland too, with the introduction of the legislation to integrate health and social care. And I think in both instances, the time is right now for leaders in the system to try and take the helm of the agenda and not be responding any longer to the legislation, but figuring out what opportunities are available to us in innovation and improvement that will help us give the patients what they want and need when they want and need it. So let's have a look at those radical redesign principles that we've been thinking about with our leaders in the Leadership Alliance. And Jennifer, if you can go to the next slide, you'll see some of those. And my suggestion to you is that although this has been created by 40-odd US healthcare organizations, actually there's much in this that could prompt a radical redesign of health and social care services wherever you are. This idea, for example, that we change the balance of power, and that co-production will become part of our of that continuum that has both innovation and improvement already featured. That we both need to standardize and reduce variation, but respond to that challenge around customization by contextualizing care to an individual's needs, by really understanding what matters. Next slide, Jennifer, please. That we have at the very heart of our thinking, and I think this was one of the early successes of the work in Scotland around health and social care integration, was a focus on outcomes. And a willingness to try and organize the service offerings around those outcomes, but they need to be outcomes that matter most to the people who are in receipt of our services. And often those are things that are really about their emotional and physical well-being as much as they are about the services that they provide. This idea of using innovation and improvement to create joy in work, I think, is really important. And I think is only going to be increasingly so as we figure out how to respond to some of those challenges. There's a very strong correlation between the extent to which there's a level of pride and joy and engagement in the workforce and the extent to which patients feel invested in. We need to use modern technologies to move knowledge, not people. We need to recognize that healthcare doesn't work in a silo, and it has to extend beyond the traditional walls. We need to learn from each other, and we need to learn from other industries. We need to assume abundance, use all of the assets that are available to us, and we need to be generous with our savings and put that money where we think it can have maximum impact, and accept that that might well be in education or social justice or somewhere else. So a set of 10 things that I think are require innovation and might lead to radical redesign, but I'm not pretending any of this is going to be easy to do. And if you just go to the next slide, Jennifer, please. I think what these radical redesign principles are giving us are some clues for the innovation that we'll need to do if we're really serious about health and social care integration and about meeting the patient's needs for integrated services. So it's telling us, I think, that we need new ways to see care through the patient's eyes. There needs to be something that goes beyond the asking of the question, what matters to you, important that is. There needs to be a response that follows up on that. That co-production and new technologies and new care models and new business models are all likely to be features of our health and social care approach, and all of them probably need innovation. And likewise, we should be thinking innovatively about new ways to liberate the workforce, to connect people to their sense of purpose and identity. Next slide, Jennifer. So why is this hard? So here's the first reason I think, and that goes back to my initial definition of innovation. Innovation needs to be about doing new things. It needs to lead to implementation. And that's often a challenge for us because the same set of skills that are required the set of skills that are required to generate ideas are often not the same as the set of skills that are required to implement those ideas. And yet, how often do we ask the person who comes up with the idea to do the implementing? So my first reason about why innovation is so difficult is, one, it really needs to be implemented. And it requires us to have intelligent approaches to implementation. Second reason, Jennifer, is that it involves making difficult decisions. I really love this quote from Steve Jobs, that I'm actually proud of the things we haven't done. I'm as proud of the things that we haven't done as the things that I have done. Innovation is saying no to 1,000 things. And that is absolutely right. That's that innovation needs resource. And we are never going to be able to devote sufficient resources to innovation if we keep doing stuff that we shouldn't do, because they don't make sense in terms of our understanding about what patients need and want from health and social care integration. So one of the reasons innovation is hard is it involves saying no to things. It involves us making the right decision easier to take. And the third reason, Jennifer, if you just go to the next slide, about why innovation is hard, is it involves persistence. And I don't know whether the number of times that Edison failed as he invented the light bulb seems to be open to interpretation. And it may or may not be 700 times, but he apparently said that it was. The point is that he persisted. And he succeeded in proving that the 700 ways or the 699 ways that he tried didn't work. And when he eliminates the ways that don't work, he'll find the way that works. Innovation needs persistence. It's a process, as I said at the very start. And we won't achieve the dividends from health and social care integration unless we're persistent with our innovations. And the fourth and final reason why I think this is so difficult is that it takes, particularly of leaders in the organization, and maybe this applies too in those systems where politics is a big issue, to the politicians in those issues, it takes some level of vulnerability to say we don't have all the answers and we need to create and innovate new ideas and changes. So it takes some vulnerability to admit that we don't have all the answers. Nevertheless, I continue to think that innovation is likely to be really important to us as we work in our various systems across the world on health and social care integration, and everybody is doing that to some extent or another. So So next slide, Jennifer. And I think the main reason for that is that, in my view, integration needs to be more than simply the uniting of two systems. And that's why I love this question posed by the Health and Social Care Alliance in Scotland about integration or transformation, because I think it's exactly the right question to ask. There are many examples of integrated systems that really haven't led to change, and certainly haven't led to improvement. And so my call to you is to try and make integration, in whatever way you're doing it in the system in which you're working, something that's more ambitious than simply the uniting of two or more systems. Next slide, Jennifer. And I'm using this slide to try and demonstrate what I mean by that. So, and again, I'm going to be somewhat, I'm going to focus somewhat on the Scottish experience thus far, because it's partly because it's the bit I know best, even after 3 years away. And that is, my sense is that the focus on integration in Scotland, and I think you could, those of you, if there's anybody on the call from Northern Ireland, I'm pretty sure they would concur with this perspective, and they've been working on integration for many, many years, is that the focus has tended to be on the left-hand side of the slide. It's tended to be on how do we create the right infrastructure for integration. What does this look like above the iceberg, above the waterline, if you think about this in iceberg terms? But that's what the structural thing is. And what we should really be interested in is what this looks like below the waterline. And what does it mean for real people living in Scotland or anywhere else? And when people who are seeking to live independently tell us that they want freedom, choice, dignity, and control, how are we bringing innovation to bear to provide them with that? And I think at some point, and this is back to our radical redesign principles, at some point the conversation needs to change from creating a workable infrastructure to actually involving people and investing in innovation. Next slide, Jennifer. Because I think these do apply in that process. Part of what we might do to make that aspiration that people seeking to live independent lives have, to live their lives with dignity and control, lies in these radical redesign principles. It lies in, I think, certainly in the changing the balance of power. It certainly lies in customization, in promoting well-being, in making it easy to do the right thing, in moving knowledge and not people, and so on and so forth. So these are almost certainly not exactly the right radical redesign principles for every context. But I do think they're a reasonable place to start as we begin to think about what innovations might be necessary to really drive better health and social care outcomes. And so just a few thoughts as we close. Next slide, Jennifer. Firstly, this needs new kinds of leadership. If we're really serious about health and social care integration, and we're really serious about radical redesign, and we're really serious about using innovative approaches to achieve that radical redesign, then that requires a new set of mental models for those who lead our systems, where leadership becomes much more about barrier removal and setting the right kind of tone and helping people to thrive, creating an environment where people can thrive, and much less about where you happen to be in any league table at any given time. Next slide, Jennifer, please. And I've been I have no commission on this book, but I'm beginning to think that I should, because I recommend it everywhere I go these days. If you haven't read this very short and brilliant book by Edgar Schein, I'm encouraging you to do so, because he helps us understand what that new kind of leadership looks like, and he describes it as humble inquiry, the gentle art of asking instead of telling. And the other thing that I've drawn from the book and used as a quote there is that idea of asking temporarily empowers the other person and temporarily makes me vulnerable. And think back to the fourth of my 4 reasons why innovation's hard, and that is because we rarely make ourselves vulnerable. So I think many of the innovative solutions to health and social care integration lie in humble inquiry. Next one, Jennifer. And they also lie in a new way to think about the culture of the organization. And I guess this is behind my suggestion that the sooner we stop thinking and worrying about the structural imperatives of legislation, and the sooner we start thinking about what really matters to the people that we serve, and we get into these questions of implicit culture, values, beliefs, sense of purpose, the sooner we will start to make progress on this. Next one, Jennifer. So where might we find those innovations then? Well, I seem to be veering between giving you a presentation here and hosting a book club, because here's another one I'm recommending to you by Stephen Johnson, which is called Where Good Ideas Come From. And Stephen Johnson identifies 7 recurring patterns in innovations. Firstly, they're usually found at the adjacent possible. So that kind of shadow reality that's just around the corner. They're not often found in the wild and distant parts, but rather in some of what we already know. They come from liquid networks, from encounters that we don't often plan. But we usually have a hunch, a gut reaction about things that often leads to innovation, that we find them by accident and serendipity, that we learn about them through trial and error, like our friend Thomas Edison would tell us. That often they're the subject of exaptation, which is that they're actually intended for another purpose altogether, and they become innovative in a different domain. They can be co-opted from their original utility into some other use, and they come from the creation of platforms for innovative thinking. And so if you need innovations to do your work in health and social care, that's likely to be where you'll find them. Next one, Jennifer. And finally, this is just my story to finish that gives me at least some sense that some of what I've said has some validity, and you might be wondering why I've got an old pair of slippers as my final slide. And that is because one of the great stories I heard about health and social care integration, I heard from a group of folks who were working on this in Lanarkshire in Scotland. And they were working on falls reduction in older people. They found that large numbers of older people were falling in their own homes, and they set about finding out why. And they discovered that a significant factor in older people falling in their own homes was that they were walking about in slippers like these, that were old, worn, ill-fitting, occasionally belonging to someone else, and that was leading to a significant proportion of falls in the home. The response to that was to introduce a slipper amnesty. So people could take their old slippers to the local library or town hall or public meeting place, and they could trade them in for a new pair that fitted them properly. And the second benefit of having the slipper amnesty was that it also gave the older person who was returning their slippers for a new pair the opportunity to interact with other older people who were doing exactly the same thing and have a conversation and get some social connection. And so the slipper amnesty got a dual benefit. My point of this is not just to say that what a great innovation, and but also to suggest to you that it's not an innovation that would ever have come out of legislation or a chief executives meeting or a boardroom of any kind. It's an innovation that can only be found by asking the folks at the point of service to find the solutions to the challenges that they face and giving them the permission to introduce those things. So you've probably had enough from me now, and I'm happy to hand you back to our hosts to get us into the question and answer piece of this.
Wonderful, Derek. Thank you so much. That's plenty of rich discussion in the chat box. Before we come to the chat box, I'm now going to introduce Arvind Varaya again. Welcome, Arvind. Welcome to the call.
Thank you, Brian.
And Arvind, any comments or questions for Derek?
Derek, thank you for an excellent presentation. Yes, I have a question. You've given a lot of reasons for innovation, but one thing that really feels authentic to me is I feel innovation is important because innovation activity can actually create fun in the workplace. In the UK healthcare, for example, there is a plan by the Q Initiative to set up labs, as they call them, where people can get together and try and find ways to solve problems, even if it's not in their own workplace that the problem occurred. My question to you is, can you see a future where such opportunities are more widely available? And do you have other such examples of where innovation can be made fun and still be harnessed for the local work? Thank you.
It's a great point, Arvind, and I think you're absolutely right that part of our duty is to introduce some fun, and innovation is often where it can be found. I can think of one really good example that Leadership Alliance group that I talked about, who came up with the radical redesign principles, introduced. So we had in the second week of January what we called Breaking the Rules Week. And what we asked people to do was to surface existing rules that were getting in the way of good patient care and to exnovate those rules and to come up with something that would lead to better care. And we got 400 ideas for rules that were getting in the way of patient care, and 400 ways of making care better, providing patients with the outcomes that they needed and wanted. And it generated a huge amount of excitement and fun. We got pictures of people who had created mugs, perhaps not quite as attractive as that QI Connect mug that Brian gave away earlier, but nevertheless pretty good. They got wristbands done for people who came up with ideas for breaking the rules. They got there were pictures of hospital foyers with Breaking the Rules Week signed out in balloons and patients contributing their ideas to how we might do that. So that's one example, I think, of innovation process that led to both new ideas and was really fun for people to get involved in. We're going to follow up on Breaking the Rules Week next year. We're going to do another Breaking the Rules Week, but we're also going to add a Remove the Checkbox Week, which again I think should be fun. So I think it's really important that we create that kind of environment where it's okay to come up with ideas.
Thank you, Derek. That's a fantastic example. Thank you.
Thanks, Derek. And we've got some chat going here. Perhaps on that last point, Michelle Watts, who's Associate Medical Director in NHS Tayside and Primary Care. Michelle was picking up on the joy at work piece and put in a little formula: happy staff equals good outcomes. But she also asked a question, which was, do happy leaders equal happy followers?
So I do think that one of the things that leaders need to do well, and this was something that was a learning experience for me, Brian, as I took on the role of NHS Scotland Chief Executive, is you need as a leader to pay some attention to yourself. And I got that advice. I had never had a coach before until I got that job, and I kind of thought, well, I'm not really sure how to do this job. I better get some advice. And one of the things I learned from my coach is that unless I took care of myself, I wasn't really going to take care of others as effectively as I could, and that was important to me. So I think there is something in leaders investing in themselves in order that they can better invest in their staff. I think the other thing that leaders could do that would help, and perhaps connects back to Arvin's question, is I think many leaders could do with not taking themselves so seriously, and to accept that it's okay for them to participate in the fun. So one of the things that we do every year at IHI, and this was way back before me, is we have the IHI Olympics. You'll have been perhaps to the Olympics, Brian, when you were a fellow. But that's held every summer. We get all the staff together. It's the kind of culmination of a whole week of working together on our strategy and approaches. And it's mildly competitive, but it's also a tremendous amount of fun. And if I don't get soaked by watery sponges this year, I'll be very surprised and also somewhat disappointed, because that's part of what makes the Olympics is that the leaders in the organisation agree to have some fun with the folks that rely on them for leadership, and I think that's really important.
Thanks very much, Derek. And it also goes to some of the points made by others in the chat box around some of the things we're talking about here, and perhaps the approach that IHI and the approach that Healthcare Improvement Scotland is increasingly taking is a bit of a challenge to command and control leadership, a point raised by a number of colleagues. I wonder if the Leadership Alliance has considered how do you deal with common command and control leadership approaches in this new world?
I think command and control leadership works poorly in areas where the solutions are likely to call for innovation. Because what are you going to command and control people to do? And so I do think there's I think there are some limited circumstances where command and control works. And some of those are I think, in healthcare. I think if we have a big public health outbreak, then you want some command and control, just as if we had a civil emergency around security, you would want someone to take command and control that situation. So I think I'm not one of those people who says there's no place for command and control. I think it's a useful thing for leaders to have in their armoury. I think it's almost certainly not the right approach in areas where that call for innovative approaches rather than for the application of simple and known interventions in a highly reliable way. So I think it's about choosing the right kind of improvement approach for the right environment and context. And sometimes I think that might well be command and control, but in my experience, more often it's not.
Nice. Yeah, thanks very much for that, Derek. And it was James Marple, a primary care physician in Lothian, that raised that question. And Andrew Winter, a consultant in HIV medicine here in Glasgow and the eHealth lead in Glasgow, raises a point around innovation. He says there's a risk of a disconnect between the £110 million spent on Scottish innovation centres and the frontline health care, where we're generally computerising on a paper-type process. He was asking, to your bridge analogy, is there something that we're missing here in Scotland around bridging the gap between health and social care, innovation, and the IT systems?
I think almost certainly. I don't think anywhere has got this, at least not that I've seen, absolutely right. And this is a world that's evolving so quickly, Brian, and changing so rapidly that your chosen solution is almost inevitably going to be imperfect at any given time. And so what I hope and trust is that Scotland is taking an approach that's adaptive, that it's learning from the decisions that it's making along the way. I think there's always a risk in setting up big centres, that there's a disconnect between the big centre and the point of service, but it's the duty of the people who are tending to the whole system to make sure that that disconnect is minimised and the risks are managed, and that the innovation work that's going on at the point of care is informing the work that the big centre is doing, and the big centre is doing things on behalf of the system. So, I mean, that maybe sounds kind of overly simplistic and obvious, but it's true nevertheless. So I think I guess I'm saying to you a couple of things. Firstly, let's not let perfect be the enemy of good. Secondly, let's learn as we go along. Let's not implement something in such a definitive way that we can adjust course as we learn about what works and what doesn't. And thirdly, for goodness sake, in Scotland, one of the big things that we have going for us is that we're small enough to get all of the right people in the same room at the same time. So let's make sure that we're doing that.
Brilliant, and I'm sure Andrew is one of those people to be in the room. Derek, I'd like to go back to a couple of points that were raised earlier in the chat box. So Fiona Montgomery, whom you know, a Deputy Director from Scottish Government, raised a question which was, would you call testing out something that someone thinks is a good idea to show that it actually doesn't work innovation? And Deborah McCraw, who's a lecturer at Napier University, thought that it was more about risk-taking rather than innovation. So testing out something that someone thinks is a great idea to show that it actually doesn't work, is that innovation?
I think not if your intent is to show that it doesn't work. That's not innovation. I think there is, I think many of the same, so I go back to some of what I said earlier. I think there's sometimes a bit of I think we sometimes waste some of our energy worrying about whether what we're doing is innovation or improvement. And there's no doubt in my mind that some early stage improvement often requires us to innovate, and some late stage innovation, as you're refining your product, it probably draws on the same iterative processes and plan, do, study, act cycles as we deploy in improvement. But innovation is about finding solutions, and rather than proving that stuff doesn't work. So only, I guess only, I would say my answer to Fiona would be only if you're proving something doesn't work in order to find a solution that does work.
Thanks for that, Derek. We've got one final, it's more a comment, but there may be a question in it from Gavin Patterson, who's a project officer with the Health and Social Care Alliance. And Gavin says that one of the programs that they're working on at the Health and Social Care Alliance Scotland is people-powered health and well-being. And it's aiming to support the health and social care partnerships with co-production. One aspect of that will be to support them to co-produce innovative models of co-production and help them navigate the barriers on working in this way. In their experience, when health and social care professionals see the benefits of co-production, it becomes very difficult for them to work in any other way. Innovation and co-production go hand in hand.
Yeah, I think that's a very, I agree wholeheartedly with that. I think that one of our underused assets when it comes to both innovation and improvement are patients and families. And I think we've traditionally been better at involving those patients and families in some elements of co-design, but we've typically been less good, I think, at involving them in co-production and making them part of the delivery solution that the innovation generates. I think the other important point in that is that innovation is often about services. It doesn't always have to be about products. I think there's people often think about innovation as the production of something, and I think it need not be about the production of anything. It might actually be about service improvement.
Derek, thank you very much for that. Now, folks, we've come to the top of the hour, and we've got some great comments from Marjolaine Dawn, Ageing at Health at NHS Forth Valley, around the cultural elements that Derek was raising. Akinola from Golden Jubilee and Anne-Marie Kavanagh out there, the nurse director, were asking a little bit more about the connection between innovation and realistic medicine, the Chief Medical Officer's report, and many other comments about culture and the analogy you set out about the bridge, Derek. So I think you've set the minds racing in the chat box amongst QI connectors, and we're absolutely delighted that Arvin could join us this afternoon. So Derek, thank you very much. It just remains for me to highlight that the next speaker on QI Connect is a wonderful man by the name of Gene Nelson, who's the Director of Population Health Measurement at the Dartmouth Institute in New Hampshire, the United States. And Gene will be speaking with us on the 27th of July between 4 and 5. And just to remind you of the wonderful QI Connect series that Jennifer and the team have brought together here for 2016, and great to have the QI Connectors so active in the chat box. So it remains for me just to remind you about the QI Connect. Please follow us on Twitter, and please stay up to date with the developments. Derek, thank you so much again for a great talk.
You're welcome, Brian. Good to speak to some old friends again. Thank you for the opportunity.
Indeed. Thank you very much, Derek. Great. Thanks from all the QI Connectors. And good night and goodbye. Thank you very much.